recording actually works. Okay, so it did yesterday. For the class, no, I don't mean the one I tried to do. The class, the class that I had yesterday, AP1. Okay, so let's go over this and see how you did it. Ready? Hematology is study blood. Leukocytes are white blood cells. Might have said what they did, but they're white blood cells. And that's fine. Predominant cells found in blood are erythrocytes. The function of a neutrophil is to fight bacteria. Viscosity of blood is referring to the thickness of blood, really. It's really what that's referring to, the resistance to flow, so that which is the same as thickness. It's important to be balanced, and you needed to tell specifically why it's important to be balanced, because this is going to be there are a lot of reasons why it needs to be balanced, but one of the things about viscosity is also playing a role in osmolarity, which means it's going to influence how water moves through the system. But it's also important to be balanced, because we said if blood's too thick, what's it putting a burden on? The heart. And if it's too thin, what's it putting a burden on? The heart. So there's a lot of different reasons that viscosity is important to be maintained. So anyway, I hope you put something that I can use. Within ABO blood typing, okay, well, whatever. I just wrote it this morning, came after it. I was still trying to figure out the recording. All right, so whatever. What I meant was, and y'all raise your hands if there's something real crazy on these quizzes that you don't know what the question is. But anyway, within the ABO blood typing, it is the presence or absence of what proteins found on red blood cells that you're looking for. What are you looking for? Antigens found on the red blood cell membranes. Antigens. That's what you're looking for, that are found on the red blood cell membranes. That's what defines blood type, isn't it? You either have the A antigens or the B antigens, or you might have both the A and the B antigens, or you might have none, 0, right? So, okay. But when considering blood transfusions and the potential problems that are caused from blood transfusions, what are the proteins that you're looking for? Antibodies, and where they're found in the plasma, aren't they? So it's antibodies that you have to ask yourself. You might know, you will know the ABO blood typing, because that'll be on their band. But you have to ask yourself, what is in this patient's plasma? And do we understand how those antibodies are inherited? Right? We do? Okay. What are henocytoblasts? You broke that word down, because there's no such thing as a big word. They're just prefixes, root words, and suffixes. These are going to be blood cells that are early. These are early blood cells. That's what that means. So great. What's a reticulocyte? It's actually an early red blood cell. Is there any reason that you might want to find reticulites in the peripheral blood, even though there should be very, very low numbers of immature cells in the peripheral blood? We have a limited amount of space inside our vessels, and our heart is pumping that blood, right? So we want everything that's in there to be mature and functioning. No slackers, right? And no babies. We need really mature, working, functioning cells. There's a limited amount of space, and there's a lot going on to push those cells around. So a reticulocyte's an early red blood cell, but every now and then we would actually like to see the numbers going up, because it would indicate that the body is responding to an event that had brought the red blood cell count down. It might have been a hemorrhagic event, which means what? You were bleeding out for some reason, maybe a gastric ulcer, maybe a trauma, maybe whatever, delivery. Not all deliveries are bloody, but some are. So whatever, right? All right. What is serum? What is serum? It's blood plasma without the blood clotting factors in it. So how can you get serum? How can you get to serum? You can draw blood and allow it to clot. Because if you've allowed it to clot, didn't it take the blood clotting factors out of the plasma to clot? So now what's remaining there is actually serum. Okay. I didn't ask you all that. I just asked you to know what it is, and it's blood plasma without the clotting factors. What's a hematocrit? What's a hematocrit? Who wants to answer that for the class? What'd you say? But what is it? It's a blood test that does what?
Percentage of cellular.
It is the percentage of blood, whole blood, that is cellular. That is cellular. It's the percent of whole blood that's cellular. Is whole blood mostly cellular? Is it mostly? Is the percentage? Is it more than 50% cellular? I told y'all this. What is the hematocrit? What is a normal hematocrit range?
36 to 48.
About 36 to 48%. I talked about it the other day. I said men have higher hematocrits than women because they have more muscle mass. But I told you that it's the percent of whole blood that is cellular. You do need to know that, okay? If you didn't know it for this, but that's okay because you'll need to know it for the test. It's going to be on this. But, and then you got a bonus, and guess what the bonus was about? Hormones. And so anyway, the bonus question was asking what is Cushing's syndrome, and Cushing's syndrome is a hypersecretion from the adrenal glands. And at this point, that should tell you all so much stuff. It should tell you, because you know what the adrenal glands release, and you know what the functions of those hormones are. So if you've got a hypersecretion of those, you should also know a lot of signs and symptoms that could be going on with Cushing. But you would have told me on this that it's a hypersecretion from the adrenal glands, specifically the cortex. It can either be because of an increased release of ACTH or a tumor of the adrenal cortex. You all knew so much about that bonus question, right? Because will you get these hormones the rest of the time? If you don't get them now, so if you didn't do well, study this weekend, because I'm going to start pushing those hormones at every opportunity I can to you. So if you didn't get them the way that you could answer those kind of questions like that, it's going to really devastate you in this course. Is that fair? Warning? Okay. So get them. All right. Great. Now we can continue on with our study of blood, and I had sort of jumped around a little bit. Here was that hematocrit that we looked at. We saw this little tube. This reminds me of something that I put up for your visible body this morning. On your visible body resource that you have, which, you know, you guys have time in here that in the lab that we aren't actively engaged in things that are doing wet lab. So that time is built in supposedly to your schedule that you can look at something like the visible body. But I put some assignments, and I put a couple of assignments that these are to support what we're doing in here and what we're doing in lab. Those assignments, and I wrote a little note on a couple of them, like especially the first one in the circulatory system assignments. I wrote you a little note saying, this is for you after we have gone over the material. This would be a great resource that you would feel comfortable being able to answer the questions. Do you have to turn in anything to me? No, this is for you, so you can use it, or you can cut your nose off, spite your face, not. But sorry, that sounded whatever, but that's really true. Use this resource, it's amazing. It really is. They have little, just 1 minute, not 10 minutes, just 1 to 2 minute clips, animations that show blood flowing, that show some disorders, that show this stuff. This is just good stuff, right? And you guys have to pay for it, so use it, okay? It really can help you. It can really, really help you. So I'm going to add a couple more things to it too, other assignments that I think would be nice for you all. But unless I ever tell you about something I want you to do and turn in or whatever, you don't have to turn in any of that stuff to me, okay? You should definitely be doing it. And I can see if y'all play the little quizzes, if y'all do the little quizzes and stuff, I can see when you've gone on, how much time you've been on there, and if you're using it. It's actually keeping up with each of y'all that have registered. It's keeping up with how much time you spend. I'm not going to judge you on it, but I'm not going to judge you on it, but please do use it. Okay. All right. So I think I had stopped talking when we stopped talking about I was talking about ABO typing and RH factor. Is that right? All right, so, and I don't know where I was in the notes, but what I'd like to do is go back to that, and I want to complete this because I really didn't get to talk too much about the RH rhesus factor, other than to say that this is also known as what? So the RH factor is also, it's called the D antigen, which is a protein that is referred to as the D as in dog, right? D antigen. And you may or may not have inherited that protein to be on the outside of your red blood cell membranes. If you have inherited that protein, you're said to be positive. Is that right? For that. So that's your RH factor that you're positive for. If you are negative, it means that neither parent gave you any information for that D antigen. So, you know, if you don't have the recipe for something, can you make it? No. So you are recessive, you do not have it. The reason I really want you all to know about this, and I wish I knew exactly where this was in the notes, but we'll see it and then I'll bring your attention to it, is because if somebody does not have the D antigen, if they are RH factor negative, they would never want to be exposed to positive blood, RH positive blood. Why not?
You have a reaction to it.
They won't have a reaction to it. They won't. But why wouldn't they want to be exposed that first time? Because then because it's foreign, they will build an antibody against it. And then the next time, if they ever got exposed, would that antibody do some trouble? That cause some trouble.
Yeah.
But here's what I need you all to know too. This is an antibody that can cross the placenta. So if a woman has been exposed, if she's negative and has been exposed to the D antigen, she will make an antibody that is not only going to protect her in case she ever sees that antigen again, that antibody can cross her placenta to the baby. What would happen if her fetus was Rh positive? If a woman had antibody that could cross, not all antibodies can cross the placenta, but this one can. And if a woman has an antibody against the D antigen, she has anti-D, and it crosses the placenta, and the fetus is Rh positive, what's it going to do to the fetus?
Protect it.
It's going to start destroying the fetus's red cells. Does that sound like that would be a good thing? That is actually called hemolytic disease of the newborn, HDN. You'll see it referred to as HDN, hemolytic disease of the newborn. What does hemolytic mean? How would you break that word down to know what it means? Lysing of blood. So now y'all are picturing what whole blood looks like. Y'all are picturing what whole blood looks like, and you're picturing that maybe the cells shouldn't be lysed, right? The cells should be intact because the plasma's got a really important job. It's 90+% water, but it's got all these other things it's carrying around in there. Should it be carrying around the inside of what was in red blood cells? And if red blood cells are lysed, can they be delivering gases to the tissues? So you've got this fetus that the mother's antibody has crossed the placenta and is now destroying the fetus's red blood cells. This, back in the day, caused stillbirths and spontaneous abortions, period. So back in the day, you know, covered wagon time. No, not really, 60 years ago. What would happen is a woman would sometimes have that first pregnancy, and that baby was fine. But if one drop of blood from that baby, as that baby was exiting, if one drop of blood from the cord blood or whatever got into a tear, and sometimes you tear, that woman's immune system would see a foreign antigen, a foreign D antigen. And what would the mother's immune system do? Make an antibody. Right? So the next time she got pregnant, and the subsequent times, if that fetus was Rh positive, the fetus's blood was destroyed. Now, what we do is that's the first blood draw that you get in prenatal care is to see if you have what your blood type is and if you're Rh negative. Fetal and maternal blood should never mix, not ever. The fetus to a mother is an alien. That fetus is only half of the mother's chromosomes. The other half came from the father. It's an alien. So the fetus is very much protected from the mother's system, and that the blood never mixes. Nutrients pass across the placenta to the fetus, and waste products from the fetus pass to the mother's blood to get rid of. So absolutely, but blood should never mix. When it does happen, it's usually because of trauma during the pregnancy or during delivery, where I told you, you can have like blood from the umbilical or you can have tears, and it only takes one drop. And it would take the mother's immune system a couple weeks or so to build up the antibody. But do we want that happening? Do we want a mother who's Rh negative to ever build or make antibody against D? No. So this is why I tell my young ladies, it's not like I don't care about the men, but it's why I tell my young ladies who look like they don't know their blood type, and these little cards, the weakest part of these cards is the D antigen. But I tell my ladies that don't get a strong reaction in D to figure out if you're Rh negative. You need to. Because you would want to know if you're Rh negative. You would know if you plan pregnancies, because if you plan pregnancies, you usually are going for prenatal care, and they're going to tell you then. And at 20 weeks of gestation, you'll get a shot of Rogam, which is a substance that would mask D antigens from the mother's immune system so that she won't see them, the immune system won't see them and be able to form antibodies. You get it at 20 weeks, just routinely, part of the routine. And you're going to, if you're Rh negative, you get it within 72 hours after delivering. So this has saved so many babies since we've understood that Rogam can be given. And it's been over 60 years, actually. I don't know the exact date, but it's been over that. So that's wonderful, isn't it? All right. So does being positive make you cuter or smarter or sweeter? No. Being negative, does that make any of those things? No. But do you want to know whether you're Rh positive or negative? Yes, you do. You won't make naturally occurring antibody against D. You would have to have been exposed to it. That's very different than the ABO blood typing. In the ABO blood typing, you do make naturally occurring antibodies to whatever antigen you didn't inherit. Are you good with that? In this blood typing issue, a lot of people think antibodies get a bad name. So they're thinking antibodies are really bad. They end up like they end up doing these terrible. Antibodies are wonderful. And we're going to see that when we get to the lymphatic system. They're wonderful. But you've got to realize that they're doing their job. Antibodies are proteins, specialized proteins that are directed against specific antigens. Okay? All right. So I wanted to finish that up. I also want you to know, just to say I said it, so it means you need to know it. HDN, that is usually what that is called, that incompatibility. It doesn't have to be just this Rh factor. It can be a few other things can cause HDN as well. But the one that I'm talking about, the Rh incompatibility with the mother being negative but making antibodies that have crossed and they're now harming the fetus. I want you all to know that the real name for that is called erythroblastosis. One word, erythroblastosis fetalis. That's in your notes somewhere, but that's the real name for HDN, the one that's the Rh incompatibility. So again, it's not a big deal if somebody's got planned pregnancies and are being responsible about whatever delivery, and it is 2019, isn't it? So those things it's not going to happen. Do we know what kwashiorkor is? Yeah. So hypoproteinemia. What does hypoproteinemia mean? Some of you had put that. Yeah, it means you don't have enough protein in the blood. And is this changing viscosity? Is this changing osmolarity? Does that change that into how, you know, things move through the system? Yeah, it does. So y'all got a clinical insight on that. Make sure you read it. Anyway, let's look at red blood cells. Let's look at them a little deeper here. We said that red blood cells on a light compound microscope will sometimes look like donuts. They'll look like they have holes in the middle. Do they really have holes in the middle? No, it's just the light is coming through. You guys will be looking at your own red blood cells next week. When you look at each field of view, most of the cells you see should be red blood cells. But every now and then you'll see nucleated white cells as well. But far and away, the majority are red blood cells. A red blood cell, a mature red blood cell, is not going to have, it's going to have lost its nucleus and the remnants of the nucleus. So it's going to have lost that, and it's going to live for about 120 days in the peripheral blood. So red blood cells aren't made and last forever. They have a shelf life, okay? But they are going to live for about 120 days circulating around. Do they ever get to slow down, or are they always on the move? Always on the move, aren't they? And because they don't have a nucleus, which is a good thing for them, they have a protein. They're made of about 1/3 of a protein called hemoglobin. And you want to know that name, that protein. It's hemoglobin. That hemoglobin protein is going to be the predominant thing inside the cytoplasm. And because it's able to be close to the surface of the red blood cell, rapid diffusion can happen. The hemoglobin molecule has a high affinity for oxygen. So oxygen will readily set up with hemoglobin, but when this red blood cell gets close to the tissue spaces where oxygen is in lower amounts, oxygen will just move right out. Now there's CO2 being given off by our cells because that's the end product of what? Aerobic respiration. CO2 is the end product of aerobic respiration. Everybody remember the equation for aerobic respiration? One of the reactants was oxygen. You have glucose and oxygen inside of your cells, and the glucose and oxygen inside of your cells can use those, and they give off CO2 and water. So an end product is CO2. And CO2 can be picked up by these red blood cells. Then the red blood cells will take CO2 to the lungs. CO2 will move out readily. Oxygen will be picked up again. And it's just this constant little cycle of red cells picking up oxygen, delivering it to tissues, picking up CO2 from tissues, and delivering it back to the lungs. So every time you breathe out, you're breathing out what? End products from aerobic respiration. Water and CO2. You are. Every time you breathe out, you're breathing out CO2 and water. Okay? So great. And so their function is these gases, this transport. These little iron molecules, there's an iron molecule inside the red blood, inside the hemoglobin. And that iron has to be available to be able to make the hemoglobin. So what might be one of many reasons why someone is anemic? And y'all told me anemia means that you don't have enough red blood cells, or maybe it's that you don't have enough red blood cells / hemoglobin. But if you don't have iron, can you make it? No, that would be like telling a builder to build me a doghouse, but not giving them any of the materials, right? It's an element that you have to have. So it's one of the more common reasons for anemia. It's called iron deficiency anemia, but certainly it's just one of many different reasons for anemia. So you have to have iron. I also want you to know something. You see the iron, the state of this iron? When you eat foods, who loves iron-rich foods? Spinach, beets, liver, right? Okay, so you know about iron-rich foods, right? When you eat iron-rich foods, and that's the best way to take in iron. I know that people do supplements or whatever, but the body doesn't respond to supplements the way it does to food. So when people take in iron-rich foods, it's in a different form, and it's going to have to be the acid in the stomach is going to have to reduce it so that we can absorb it. We can't absorb it as the 3+. We have to reduce it. So tell me another reason why you might be iron deficient then if I just said that.
They won't stick in the intestines.
Well, it won't be absorbed in the intestines unless it gets to this. But what is helping it to be reduced? Stomach acid. So what about those people who chew on antacids all day long? Do you think that might be affecting their iron uptake? Do you think it could? So people who have stomach issues might be iron deficient? Is that right? Because it takes the stomach acids to reduce this? Is that right? Okay, that's true. And that is true. So just because somebody tells you you're iron deficient, it might not have anything to do with you not taking in enough iron. It might have to do that you don't have what working like it should. Your stomach's not secreting the acid at the quantities or at the times that you need it to reduce the iron, and then it can't be absorbed. And then there's going to be other reasons too. But anyway, that's good for you to be thinking about.
So it starts at Fe3.
Mm-hmm. Yeah, but I'm not going to ask that. But yes, it does get reduced to that. Okay, so I told you that men have a higher hematocrit, don't they? Men have more red blood cells. So when we think about men, and some men actually even push over 50%, you know, but it's influenced by how hydrated they are and if they're dehydrated. But do we want men to have too many red blood cells? Because if their blood's too thick, what's that probably putting heart up? Okay, whatever. So you get that. You said, okay, I'm gonna stop stuttering. Maybe. All right. So great. Here's what I'd like you to see though, and I'm not going to ask you about it. But if you go into pathology, you would, this is what pathologists are doing for diagnostic medicine, and people should be able to interpret this. But you'll kind of notice that, let's say a woman has, and I said 36 because many are about 36. So, by the way, these norms are also created based on populations in regions. There are some regions that have higher slightly norms than others. What do you think is influencing that? The environment. And do you think weather plays a role in that? Yes. It absolutely does, right? So in local hospitals, larger hospitals, they pool blood to get their norms. They take about 200, and they do this routinely. They'll take about 200 blood samples and pool them and then get norms from that. But anyway, so let's say 36 just because it's an easy number to think about. What we'd like to see is this kind of thirds relationship. So I told you, so we've got about a 36% hematocrit. And then as far as the hemoglobin, I told you about a third of a red blood cell is going to be hemoglobin. So what you should see is about 12, and this is grams per deciliter. But anyway, and then you should see about a third of that being the actual count in millions per microliter of blood. So you see 36, 12, and 4. Was that like a thirds kind of relation? I'm never going to ask you that, but you do like to see that. Those of you who have looked at CBCs, and what does the CBC stand for? Complete blood count. Complete blood count. This is all given in a complete blood count. The hematocrit, the hemoglobin, and then also the count, the actual count of cells, a million per microliter. Now look. If that range is off, you guys who've looked at lab reports have seen things called MCV, MCHC, MCH. Janet Sand, yeah, she's seen those. Those are called indices, and that's based on that relationship. Because the fact is, you can have some people who are trying to push out red blood cells, but those whole red blood cells are empty. There's no hemoglobin now. The hemoglobin's way down, way off. You get what I mean? So you want red cells to be made, but you want them being made the way they're supposed to be made, with about a third hemoglobin that's functioning. So that's what those indices give you. And that's all given in a complete blood count. So all of those things are actually available to you with that. So great. And we talked about getting to this. And how long do red blood cells live? 3 days. They live for about 120 days. And this is a little visual about how iron has to be reduced here by the acid in the stomach. before it can even be absorbed. But I don't ask you this either, but there is something called, if somebody gets told they're iron deficient, they have iron deficiency anemia and they get prescribed taking iron, but then nobody ever checks up on it, that's really like a ridiculous shame. Because is it normal to be anemic? It is not. So people should follow up on it. And if they really find out the person really was increasing their iron-rich foods in their diet, plus maybe taking iron supplements, and still the numbers were off, then they do need to look at the stomach. They need to look at the GI tract, see what's going on there. But look what else. You can actually be absorbing it, but if you don't have the little transfer proteins, these transfer proteins to move it around the system, you're still going to be iron deficient. So there's a test that can be done for somebody who has continued to have anemia, even though iron has been supplemented. It's called a TIBC. It's a total iron binding capacity. And then a TIBC, have you seen that, Janet, as far as tests go? Yeah, but yeah, that's because people, yeah, because people just let people go walk around anemic, right? Because you kind of get used to it. It is one of those things that people sort of tolerate. But anyway, TIBC is going to look at all of these levels, and it's going to tell you what might be going on, and then they have to address it from there. Anyway, so that's total iron binding capacity, TIBC. That's not in your book. I'm not going to ask you about it. Just want you to know, people shouldn't just go around being anemic and not address it. It should be corrected. Okay, so, and this gives a lot of stuff. All right, now really also want you to know about something else. And this is, again, iron isn't the only thing that you need for that hemoglobin. You also need vitamin B12, folic acid, these vitamin B complexes to make red blood cells. Everybody, so these are the building materials for red blood cells. Iron, vitamin B12, folic acid, some vitamin C, and some other things. So you know you need these as the building materials. How many of you know, and I always say little old ladies, because it's not always women, sometimes men get B12 shots, but how many of you know people who get B12 shots and they swear about them? They like can't function without their B12 shots. And they get the little B12 shot and they get a real boost. Why did they get a boost? Because they got the B12 shot, and did their red cell count really go up? Did it go up a little bit? Did the hemoglobin fraction go up? And when it did, what was being delivered to cells? And what were the cells able to do? Work. And did they feel better?
Sure.
That's a real thing. That's not crazy.
I get one weekly.
That's a real thing that people do. You do? You might be young for that. Okay. Is that right there? So, you do have some. So,
Brandy got the red hair.
yeah, I know she did. You got some too. So, anyway, absolutely, this is needed. Now, let me say this. Do you remember the stomach? Did the stomach play a role in getting iron in the system? Did the stomach play a role? Because by producing acid, right, which is necessary for a lot of reasons, iron, just one of them. But let me tell you something else the stomach produces, and I need you all to know this here with the vitamin B12 thing. The stomach produces a factor called intrinsic factor. Intrinsic factor. So this is a chemical. You can think of it, I don't care if you put it in your hormone list, you go ahead and do it. And if you learn it now, which you're going to need it now, it'll help you when we get to the GI tract, because you'll see it again. But anyway, intrinsic factor is absolutely necessary for vitamin B12 and folic acid absorption. Absolutely necessary. Intrinsic factor from where?
The stomach.
The stomach is absolutely necessary for vitamin B12 and folic acid to be absorbed. So again, as people age, or if they have a deficiency of intrinsic factor, if they have a deficiency, and they may have a deficiency from young age. This is called pernicious anemia. Have y'all heard of pernicious anemia? So pernicious anemia. So this is a definitive diagnosis. Is anemia a definitive diagnosis? No. That just tells you have a low red count or hemoglobin, but you don't know why. You might have iron deficiency anemia. Now do you know why? Because of the iron. But you might have what's called pernicious anemia, which means you don't make intrinsic factor at the rate that you need to, and so you are now what deficient? B12, folic acid deficient. Pernicious anemia. Are we good with that? There's another type of anemia. It's called aplastic anemia, and you don't ever want to hear this diagnosis, because aplastic anemia means that you're not making any red blood cells. The cause is usually unknown. So the cause of aplastic anemia is usually unknown. There are some ideas out there, but it means that your bone marrow, those blasts in the bone marrow, are not producing red cells. That just doesn't even sound like a good thing, does it? And it's not. It's usually a very end sort of terminal type of diagnosis. Okay, so these are some of the things. Now, we said that these words, hypoxemia, would simply mean low oxygen in the bloodstream, wouldn't it? Hypoxemia. So your blood is being filtered in the kidney. It's also being filtered in the liver. But we said your kidneys produce most of the erythropoietin, doesn't it? Most of it. What a perfect place for there to be specialized cells that are monitoring oxygen levels. Because if the oxygen levels get low, that's okay. The kidneys release what? Erythropoietin. It targets the red bone marrow. The red bone marrow, the hemocytoblasts become erythrocytes. Now your red count goes back up, and what increased? Your oxygen levels. So a classic negative feedback, isn't that right? Classic. So this is what we want to see. Stimulations for erythropoiesis, just the process of making new erythrocytes. If you're exposed, all of a sudden you go to higher altitudes. If you go to higher altitudes, what do we know happens to oxygen levels? They decrease. So as oxygen levels are decreasing in the atmosphere, you're becoming hypoxic. So do you want this process happening? You certainly do, right? This is why athletes who are playing in different places, like professional athletes, or even whatever, that go to different areas of the country to play sports, they'll usually go several days ahead, and they'll acclimate themselves to the different atmosphere, right? Because this is going to help them. This is why you've also heard, and this is a very incredibly bad thing, you've heard of blood doping. Have you heard of blood doping? Blood doping is when these, you know, Lance Armstrong, y'all everybody knows Lance Armstrong from the Tour de France, took all his medals away from him. But he wasn't the only one. It was a lot of athletes will do blood doping, where they will inject themselves with erythropoietin, EPO, erythropoietin. And even some of them have gotten, I don't know how they get this, but packed cells. Now, when these athletes are doing that to bump up their red cell count, what's that changing in their blood? The viscosity, the hematocrit, the viscosity. And what's that putting a burden on? And do they already have a lot of burden on their heart because they're usually doing stuff? So this is why you hear about blood doping causing these people who are in the prime of their lives to die of sudden heart attacks, because they have, right? And it's why it's banned to do that, because it's a very dangerous practice, isn't it? So anyway, but this is what should happen normally, though. So how about if you just start increasing your exercise regimen? Are you going to need more red blood cells? And your body can do that. So if you start a exercise routine, that's why they say there's a safe way to do it, you know, and depending on your age and your overall health when you go in, but this is a safe way to do it. And then obviously, guys, if somebody has respiratory disease, and they their lungs are not able to move that air to the red cells. What did I tell you? Red blood cells are being sent to the lungs to drop off CO2 and pick up oxygen, right? But if the lungs aren't working as they should, is this going to make them hypoxic? Yes, so they're going to have hypoxemia, and they're going to, here's the bad news about that. Here's the bad news about that, and I'm going to introduce it right now, just because it's this important. The bad news about that is that people who have chronic lung disease, they are slightly hypoxic. Do their kidneys know it's because of the lungs, or do their kidneys just know that they're hypoxic? The kidneys just know that, so they're releasing erythropoietin. What's happening to their red count? It's going up. So what's changing in their blood? Their viscosity. What's it putting a burden on? Their heart. So I have said this in class, and it sounds, I don't mean to sound cold, because it's horrible. But I've said the good news about people with really severe lung disease is they often die of a heart attack before they suffocate. And why do they die of a heart attack before they suffocate? Because it's putting such a chronic, long-term strain on the heart. So it's usually the heart that gives in before they can suffocate. People who are in end-stage emphysema, though, will suffocate completely until they've lost consciousness dozens of times a day before their heart gives out. Emphysema. Do we know what 99+ emphysema is caused from? Smoking. So that means it's preventable. Did you all see that the state legislature passed that smoking would be pushed up to 21 instead of 18? Did you see that? How do you feel about that? What'd you say?
It's still not going to stop me from smoking.
Yeah, you're right. You're right. Actually, the numbers of smokers are going down, and it's through education. People understanding that. And when you look at the demographics of who smokes, you probably don't want to be in that category. So if smokers really looked at the demographics of who's smoking, but it's a legal drug business in this country. And I'm not shaming the farmers, but you know, there's no positives, none to it. And if you wait till your first patient dies of emphysema, that actually dies from emphysema, that you have, and you might sort of change your mind. But like I said, most won't. Most will die of a heart attack first. How many of you know anybody in end-stage emphysema? Does anybody know anybody in end-stage emphysema? Nobody? It's a horrific death. It is one of the worst deaths that you will see as a primary care practitioner. One of the worst. And it's preventable. So anyway, so we're talking about oxygen, and that is okay. So okay. Now, so what happens is we said if you have too many red blood cells, then this is called polycythemia. How would we break that word down? Poly always means what? Many. Cyte, cells, emia, in the bloodstream. And we know the predominant cells in the bloodstream are erythrocytes. So you have too many, and that's going to really put a burden on the entire system. Now, let's look at death and disposal. We looked at some erythrocytes because we said they only live for about 120 days. I would want you all to know that the spleen, never mentioned that yet, the spleen plays a huge role in helping to filter blood too. So we talked about the kidneys, the liver, and now the spleen. The spleen plays a huge role in that, but the spleen is also a blood reservoir. So this is where blood is often held, if you will, but it also is going to be the site where irregular and old red blood cells get pulled out of the system. They're going to get pulled out of the peripheral blood. Because do we need old red blood cells in the system? Old has a whole new meaning to me now. But okay, no, we don't need old red cells in the system, and we don't need ones that have irregular shapes in the system for blood. Because I told you that that's a finite amount of space, and we need the things that are working, being pumped around, right? So the spleen plays a huge role in this. And what I want you to know, and we remember this from our skin, don't we? And when we're talking about skin, is when you think about hemoglobin, heme is the pigmented molecule that's in this protein called hemoglobin. The globin part is made of amino acids. Don't we know proteins are made of amino acids? So what the liver and the spleen are going to do in conjunction, the liver is going to produce enzymes that break down this hemoglobin. So we can reuse those amino acids and build new proteins, right? Because amino acids are those building blocks for proteins. So what a perfect recycling machine we have here. The liver is necessary in producing enzymes that break it down. So if the liver is not producing the enzymes to break it down, this heme part, the pigment part, then what ends up happening is we can't go from heme to biliverdin to bilirubin to bile, and bile would be released into the liver ducts that would end up going into the small intestines. Bile is absolutely necessary for fat absorption. Are fats good things or bad? They're good, unless you like the kind I do. But no, most of them are good. You have to have fats, right? So you have to have fats. And if you don't have bile, you can't absorb fats. This is just like a perfect recycling machine here when it's working. If the liver is not producing the enzymes necessary to break down old red blood cells, and you have millions breaking down every second of your life, then what can happen is this heme, this pigmented part of it, can start, it doesn't get past the bilirubin stage, and bilirubin starts to build up in your system. And this bilirubin building up in your system is going to give you a sign of disease. What is the sign when bilirubin's building up in your system? What signs do you have of that? Jaundice. So everybody remembers jaundice is that yellowing, that and yellowing, orangey of the skin and of the whites of the eyes, the sclera, right? Where bilirubin is building up. And it's building up because the liver's not producing what it should be producing. So it's one of the first signs that the liver is stressed, isn't it? And the liver might be stressed because of viruses like hepatitis A, hepatitis B, or hepatitis C, or any of the other viruses that can attack the liver. The liver might be stressed because of substance abuse, right? The liver might be stressed because of autoimmune diseases. The liver can be stressed. So if it's stressed, one of the first signs is jaundice. And jaundice is simply that you're actually seeing bilirubin building up in the tissues, and you have a visual of it. What's wrong with bilirubin? Yellow's not a bad color. I like yellow. What's wrong with bilirubin?
Is it neurotoxic?
It's neurotoxic. So if it's building up enough that you can see it, it's damaging what entire system. And what entire system controls all homeostasis? The nervous system. Right. So anyway, but this is how we get rid of red blood cells. I mean, you know, when they're on their way out. So polycythemia, we said, we don't want too many red blood cells. It has to be just right. This is this Goldilocks thing I told you. Homeostasis is like thinking about Goldilocks. Things can't be too much, too little. They have to be just right. Even if they sound like wonderful things, too much of a wonderful thing is it's going to end up being toxic to your system. So things have to be just right. There's two different types of polycythemia. One is the primary, and then the secondary. And this is, when we use the terms primary and secondary in disease, these terms are used the same for any kind of disease we might be talking about. So let me first explain primary polycythemia, but then I'll give you another example of something other that's like this. So primary is always meaning that this is your disease. This is what is the disease. So if you have primary polycythemia, it means that you have cancer of that erythropoietic line. And so your hematocrit, instead of being 40, is now what? Like 80%. Do you guys know what blood would look like if you had a hematocrit of 80%? It would look like sludge. Can you survive this? No, you're going to have to be, you know, that whole thing about bleeding. Do we still use leeches in medicine?
Yeah.
Yes, leeches are still used in medicine, just in the last, like, it was maybe 10 years ago, the first mechanical leach, and it was done at UVA, has the patent on that. But anyway, was devised, but they still use medical leeches. So sometimes you really do have to get rid of red blood cells. A leach wouldn't be the best way to do it in this case. The best way to do it in this case would be through pheresis, where you're removing blood, just removing red cells and putting, you know, the other back, some red cells. But anyway, so this is primary. Secondary means that you have a high red count, but it's because of something else that's causing it. Does that make sense? So you have, and I talked to you about emphysema. Why would emphysema give you polycythemia? Because your poor kidneys think that you're hypoxic, but are you? I mean, yeah, you are, but it's not because you don't have enough red blood cells. It's because your lungs don't work. So certainly any respiratory diseases. You can also have secondary polycythemia because of being dehydrated. Now this is important. This is why people, when they look at lab reports, better look at the whole report and better be paying attention to the whole thing. And this is a true story. Because y'all are thinking about that hematocrit, but we said that the predominant part of blood is plasma, and plasma is mostly what? Water. So if you're dehydrated, what's it going to appear? It's going to appear like your hematocrit's higher, right? I have a sister who I knew was severely anemic. I said, go, because you're severely anemic. Something's got to be done. And she said, but my lab report, look, I said, send it to me. So she sent it. And her hematocrit looked okay. But when you looked at the osmolarity and you looked at some of the other supporting data, she was severely dehydrated. So that was throwing that off. Do you get what I'm saying? You have to look at it, the whole pictures to know what's going on. But anyway, so these are some of the reasons you can have secondary polycythemia. None of them are good, are they? Because what's it putting a burden on? The heart. It's putting a burden on the heart. So the dangers, you've got increased blood volume, pressure, viscosity. This can lead to an embolism, stroke, or heart failure. Listen, I want you all to know the difference between thrombosis and an embolism. Write down thrombosis and then write down embolism. We're getting a little ahead, but that's okay. You will have it in a bit. But a thrombosis is a clot, a blood clot in an unbroken vessel. Are we happy that our blood can clot when it needs to? Yeah, and our blood, we need to have clots formed when we've had damage to our vessels, right, and tissues. We need blood clots. But if it's an unbroken vessel, do you want a blood clot in there? Would you want a blood clot in an unbroken vessel? No, so thrombosis means a blood clot in an unbroken vessel. Now, there's something called an embolism, which is a blood clot that's moving. It's not stationary, it's moving. And we understand that if it's moving, blood is eventually going to get returned to the where? The lungs and the heart. And if it hits one of those, and you know somebody who ended up surviving a pulmonary embolism, they should go buy a lottery ticket, because they're really, really lucky they survived it. Most don't. So embolisms. Embolisms are moving blood clots. Y'all have heard of DVTs. What's DVT stand for? Say it loud, Janet. It stands for deep vein thrombosis. You've heard of DVTs, people who have DVTs. They have deep vein thrombosis. They often have them in their legs. And a lot of times it's because people are not moving around enough. Maybe they've been in, and sometimes they can't help it because they're in, our soldiers have to be really worried about that because they get in these like foxhole situations, whatever, and they don't move for days. And if they're not, is that impeding blood flow back to the heart? It is. So in these veins, blood can pool. And when blood is not moving at the rate it should be moving, what can form? In an unbroken vessel, what can form? A blood clot. So if that blood clot forms, it better dissolve before it starts moving, because if it starts moving, it's going to eventually get to the heart and then the lungs. And again, this is deadly. Okay? Something like, and I think your textbook says this, in your textbook's relatively new information, something like 650,000 Americans die. And that number doesn't sound right to me. But anyway, from thromboembolisms each year, that's a lot, isn't it? So sometimes it might not even be being told to the people that die. They may on their death certificate be advanced heart disease. That's what they're putting, right? Or they're putting other things. But what really ended up taking them out, because that quick can take you out if it hits the lung or the heart, is this embolism. Okay, so this is what we mean by cerebrovascular accident or stroke. Did that just spark? Okay, so, all right. I keep thinking I have to use that. Now, I've already talked about anemia, haven't I? I've talked about anemia, and I've said that you can have kidney failure. And if you have kidney failure, you're not making erythropoietin. Is that going to make you anemic? Yep. You can have iron deficiency, can't you? You can have iron deficiency. You can have pernicious anemia. You can have aplastic anemia. You can have, and I didn't really talk about hypoplastic. That's just slowing down. But hypoplastic anemia can sometimes be seen when people are on certain medications. So especially chemotherapeutics for cancer. So when y'all have heard of people who have had chemotherapeutics in their cancer regimen, you'll sometimes hear about people who get these boosts. They'll get like a shot for white cells to be boosted, but also their red cell, erythropoietin. Okay, whatever. So, but hemorrhagic means that you're doing what? You're bleeding out. Hemolytic means that hemolytic disease, anemias are usually because you have gotten an infection, and some bacteria, some organisms, microorganisms have hemolytic properties, which means that they can start lysing your blood. It's not nice at all. So, you know, that's dangerous. And those of you in my micro class, we talk about infectious diseases are the most rapidly devastating for these diseases for people. But the ones that have hemolytic properties like Staphylococcus aureus and Escherichia coli and many others, they're the ones we really worry about because they're the ones that can do that. So anyway, so hemolytic. So, all right. So what happens? What happens if you don't have enough oxygen? They're not crazy, Dylan. They really are lethargic. What is lethargic? What's lethargic? Lethargy. Lethargy or being lethargic means tired. You're just tired, fatigued, don't have the amount of energy you typically do. The thing about many of these anemias is that they come on in a chronic kind of situation instead of acutely. If they happened acutely, people would notice it and usually are going to complain or go see about it. But many of the things you just heard about, kidney failure, can be over a long period of time. Some of these other anemias, it happens so long that people adjust. You will have people come into your emergency rooms. Janet, where do you work? The rehab. You'll have people come into your emergency rooms and you'll run some labs and you'll get them back and think, well, that can't be because they wouldn't be talking to me. They wouldn't be talking to me with this kind of oxygen perfusion. This is not happening. Or this hematocrit. They wouldn't be walking, right? You'll see it too with glucose levels, where these people should be either in a coma or whatever, and you'll think to yourself, how are they even functioning? Let me tell you about the human body. It's amazing. If things don't come on slowly in a chronic kind of situation, the body will start to adjust to it. I'm not saying it's going to be good for the body. It won't be good at all for it. But the body will start to kind of adjust to it. And, you know, then you get the person in and you think, okay, we got to reverse this. We got to reverse what's happening. Because if those numbers were in somebody that were healthy, if they all of a sudden happen to that person would be out, wouldn't be able to survive it at all. This is also why in your emergency rooms, and we'll talk about it a little bit when we get to the part two, on autopsy, sometimes you can see people that you can look at their hearts and you can see they've had a dozen heart attacks. Now, of course, they're dead at that point because you're looking at the autopsy. You're looking at the heart. But you can see that these heart attacks happened long ago. They're already scarred over. They had a lot of heart attacks. Then you get this young person in there in their 40s, and that's young, 50s. And they had suddenly a heart attack. You look at their heart, and that was just that one heart attack. It didn't even look like it was, you know, but they were young, and it happened suddenly, and their body couldn't adjust to it. Their immune system was overreacted to it, and it took them out. So you have to think about how these things are happening like that, but they really do. So some of the things that are also going on, the osmolarity we said is going to end up leading to edema, which is, you know, putting pressure on the tissues and the heart. Viscosity, again, heart failure. This is what you're worrying about with that. Sickle cell disease. Sickle cell disease. Don't take a break. Let's take a 10-minute break. We're going to come back to sickle cell, okay? 10 minutes. I maybe got a little more than I wanted. Okay, guys, so I apologize. You know, I really shouldn't have made you get that 10-minute break. I should have gone on because some of you get to leave. Raise your hands if you get to leave after this because you've already done your blood typing and stuff. So some of you get to leave. I apologize to you guys because y'all could have. But let's just do a little bit more. I wanted to continue what I was talking about with people who come in who have chronic conditions that are lasting for a long time and it's going kind of slowly. Those people can seem to survive for longer than people who have things that happen suddenly to them. And you will definitely see this. You will see this. You will see people come in to your emergency rooms and whatnot who had, you know, they had like 5 different chronic illnesses that one in an acute phase would have killed a young person. But they're like juggling 5. And so then the meds are crazy, whatever. It just can take a really, it's just amazing what the human body can do. And then I guess I should say they can't do in some situations when things happen suddenly. So when things happen suddenly, the body can't accommodate it. And that's when you usually have bad outcomes. So you see somebody young coming in with chest pain. When I say young, 40s, 50s, you better take it seriously because you're going to lose them quicker than you lose the 97-year-old that's had a dozen heart attacks already. It's just the way that it is. So anyway, sickle cell, this is about sickle cell disease. This is an inherited disorder. It's an autosomal recessive disorder, which means that the information is found on that first through the 22nd pair of chromosomes. And we understand that what happens in sickle cell disease in this particular disorder is that a sickler has inherited 2 recessive traits, one from each parent. So a sickler is going to be like this. They got one of those chromosomes from their mom and one from their dad. I can't tell you how many sicklers you'll have parents who come in and they'll have a child who has sickle cell and neither the parents have it, but the child has it and one of the parents will say, well, that wasn't on my side of the family. That was on so. Yes, it was, because they both had to give a trait. You understand that? It's an autosomal recessive inherited disorder. So that means is that if they have at least just one of their chromosomes with the normal recipe for hemoglobin, they will not have the disease. They will just be called the carrier, and they will not have the disease, right? Are we good with this? Now, this is the heterozygous condition for that they are a carrier for it, and they have a 50-50 chance of sending this chromosome to each of their children, a 50-50. If they mate with someone who also has it, then it ends up being, if you did that little Punnett square, 1 in 4 chance of their child would have it with each mating, right? All right, so, and we said that this is one of those mutations that occurred that actually ended up becoming an adaptive mutation, even though it's devastating. Because if somebody has this disorder before modern medicine, they died before puberty. Before modern medicine. They died of what? Sickle cell disease. Now with modern medicine, sicklers who can prevent crisis and can, you know, be really proactive in their health, they can live normal lifespans. That's phenomenal because before modern medicine, they didn't make it to puberty. Everybody with me on that? A person who has normal hemoglobin from both parents, obviously you're not going to have a hemoglobin problem, are they? But if they live in arid regions where there's a lot of mosquitoes, the Anopheles mosquito that carries a protozoa called Plasmodium, they're going to die from malaria before modern medicine, and still many do. Many die, more than 1 million. It's hard for Americans to get our head around this number. We think it's all about us in America. We're only 5% of the population. 1 million people die from malaria, a protozoal disease, every year. And they have this. But this condition, this mutation that happened way back when, this mutation, if they're heterozygous, it protects them from malaria. And do they have sickle cell? No. So actually, this is how a trait that we tend to think of as being kind of devastating, right, is actually adaptive in the heterozygous condition because it's offering immunity to malaria. The protozoa that cause malaria, part of their life cycle is inside of a human's red blood cell. And this human's red blood cell doesn't taste good to those protozoa. They can't do what they normally would do that would end up taking somebody out. It doesn't offer them complete protection, but it offers them some. And this is why this has stayed in the population and the high numbers that it has stayed in. And it's also why it's in the darker tone people. You know, we think about this being the predominant inherited disorder of Black people, darker tone people. Darker tone people have come from the equatorial regions where there's a lot of sun, and melanin protects them from what? Melanin in their skin, darker melanin protects them from what? UVA and UVB rays. So we see it more in that population. Yeah, so, okay, any questions about that? Now, what this is doing is just, it's having multiple organ system effects, because obviously blood is a liquid connective tissue that's delivering nutrients to all the body's tissues and picking up waste. But what happens with this abnormal hemoglobin, it causes the red cells to sickle. And I've got a blood film that we'll see next week when we're looking at our blood films, and you'll be able to see. And they lose the ability to wiggle and move through capillaries. Where nutrients and gas exchanges and waste exchanges are happening is at the capillary level to the tissues, which is 1 cell layer thick. Capillaries are for rapid diffusion. And they're so small, blood capillaries that nourish our tissues are so small, these vessels, that red cells have to go through them single file. They have to be able to be wiggly and squiggly, right? But when they become rigid and done this, are they moving? No. And this can lead to kidney, because the kidneys are filtering this, kidney, heart failure, stroke, joint pain, rheumatism, and even nervous system problems. Now, I have told you about blood typing, so we can go through that. Wait a minute. Is the sickle? Okay, well, is thalassemia in here anywhere? It should be in here. Wow. Okay. There are other hemoglobin disorders. And I would want you to know, this is talking about a woman, first-time pregnancy, no big deal. But if she builds antibodies, those antibodies can cross and attack the next ones, right? So these are good visuals for you. But actually, I want to tell you just quickly about thalassemia, and then I'll let someone do. Thalassemia, there's a thalassemia major and a thalassemia minor. These are also inherited. It's an inherited hemoglobin disorder of mostly people of the Mediterranean descent. But what this disorder does, usually people can live with this one. It's not usually considered nearly as awful as sickle cell hemoglobin disorder. But thalassemia, these thalassemias can cause people, instead of having like 4 million red blood cells per microliter, they'll have half that number. But have they become accustomed to it? Yeah, and their bodies have become accustomed to it, and their bodies kind of acclimate to that. But you do have to be cautious of them, because if you have somebody coming in that has that, and then you have things happening like pregnancies or other diseases that can put a little bit added burden on the system, which you want to be really cautious with them, and maybe even those people who have that particular inherited disorder, the thalassemias, are going to have to be maybe getting transfusions and that sort of thing during those crisis times, right? All right, so I'm sorry. So that's all. I should have done that, finished that out, and let you all just leave happily later. You need to go first? Okay. Come over here. I'm going to do it. I'm going to do it. Who's here? Who's saying? Let me see how many. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. Oh, yeah. Yeah. Okay, sorry. Thank y'all for keeping up with me. That's everyone.